Behind every master was once a curious student. Every clinical pearl has been earned through years of trial, error, and evolution. Behind every success are stories, challenges, and a unique journey. I'm Dr. David Norcross, and this is Clinical Curiosities, conversations with specialists, innovators, and experts who help move our industry forward. We've got Associate Professor Max Guazzatto. We've just been having a conversation about how we pronounce the surname. I presume in Australia it's Guazzatto, but you can say the proper pronunciation. And Max, we've met briefly on a number of occasions at different conferences. One of the benefits of coming to these is I get to meet people like yourself. And I have to say that after our brief conversations that we had, I came away with I just thought this guy is very knowledgeable in a lot of areas, and I'd love to have him on for a proper chat. So that's why I've dragged you away. We're obviously at the Nobel Symposium, so I'm mindful of time. So you are a little intro. You are a prosthodontist based in Sydney, but you're originally from Italy, and you were a master dental technician and oral surgeon. Is that correct?
Yes,
cool.
That was mine.
And then you did your specialist training in Sydney with also a specialist degree, a PhD in Zirconia. You've published 2 books.
Ceramics in general.
Okay. You published 2 books and over 32 articles.
Contributed to 3 books.
And articles around 32?
Yeah.
And building?
Maybe 50.
50. Unbelievable. Okay.
Yeah, 50.
So our first question is, why so much education, and why all these specialties? What was the...
It's a weird question from you, because I saw your Instagram training and I can see you're a full-on person.
Yeah.
So to me, it's pretty much the same thing in dentistry. I do believe in formal education.
Yeah.
Because it pushes me.
Yes.
So exactly as you train, exactly as you work.
Yeah.
You want to be pushed. We tend to be everybody a bit lazy.
Yeah.
So if I have a deadline, a commitment, a degree, and that forces me to study.
Yeah.
So it's not only passion, it's also discipline.
Yeah.
So I find it easier for my personality to have a commitment.
Yeah.
And I say so. And I was lucky because after dentistry, I was invited to attend this semi-experimental residency. It was the early stage of our postgraduate.
Yep.
And I really didn't I didn't apply. I was invited during one of these events, basically by my mentor at the time, and then moved to Australia. And I thought that it was the best way to integrate is to do something at university rather than going to Bondi Beach and play volleyball, which I enjoy.
Yeah.
So that's how the PhD came. And then, the more you study, the more you know, the more you're curious about, the more you want to know, and keeps going this way. Plus, I take my confidence from competence. If I don't know something, I find it very difficult to jump into it. And then, there's some people that are magic. They just learn as they do.
Yeah.
But I need to know before, and then I do it. I think that's the reason for the all.
I think the specialists that I have spoken to, it's about that pursuit of knowledge, constant pursuit of knowledge. I've spoken to prosthodontists, periodontists, and it's kind of wanting to know as much as they can to then take into the daily practice. So you've obviously dedicated your life to that learning. So I would say
I can see you're the same mindset.
I have. I mean, I
can see the discipline, the commitment.
Yeah.
Yes.
I think, for me, obviously, I didn't go down the specialist training path. I wasn't a great student, but now I'm in the profession, constantly seeking more knowledge and, in the pursuit of excellence in your life.
There's different way to get there.
Yeah.
I think probably if you want to dig more into psychology, mine comes also from, my background is my parents survived the Second World War.
Yeah.
And they have no education. My mom became a fashion designer, manufacturer, and nobody has ever told me study, go to university, and nobody has ever given me a feedback as a kid. So the feedback came in the university.
Yeah.
You study, you perform, you're a good boy.
Yeah.
You don't perform, I punish you. I saw some degree of fairness,
and
I got stuck to that.
Yeah.
So that was my way in life. So
yeah.
And it's good to have a feedback. I love feedbacks from colleagues. You need to be able to take it.
Absolutely.
But I think I really enjoy that. University gave me feedback. I work in a team. I ask all my colleagues, what do you think about this? What do you think? And I never get offended.
Yeah.
It is what it is.
Yeah. Obviously, mindful of time, there's so much I'd love to ask you because you are so knowledgeable. But I thought we'd touch on 2 fascinating topics that I get asked about a lot when we're mentoring, teaching or whatever. One is zirconia. Okay, you obviously have your PhD in
Zirconia,
in ceramics. It's obviously a material that we're utilizing a lot more. You're probably, one of the more qualified people to talk about it. So obviously we're shifting now in full arch. It's what I do a lot of, from the titanium and acrylic structures and PFM to more monolithic zirconia materials. What are your thoughts around that and the controversy associated with that?
Okay, let's go back maybe 20 years.
Yeah.
So when I was working on my PhD, there was a multiple type of zirconia, and they're still available, but not to us.
Yeah.
So I saw the potential was huge. And some of these materials were amazing mechanical properties, but they didn't win the commercial race. So some companies like Noritake, for example, decided not, or Matsushita or Panasonic, mainly Japanese, decided not to put this type of material into dentistry. But the reason why my interests were on zirconia in particular is because I saw biocompatibility, aesthetics, stain resistant, all properties that you want to have. It also wear resistant, and it also doesn't wear your post-dentation as much as other materials. So it ticks all boxes. Plus, the material that won in dentistry, the 3Y that we know, it's got to be aesthetics. You can stain it, you can milligreen stage, you can do lots of things. So it's very versatile. It's actually not the best from the mechanical properties. There are materials that are much tougher and will be much better. So these materials are becoming potentially very interesting now, because full arches from FP3, there's a tendency to move into FP1.
Yeah.
And as the restorative becomes smaller and smaller and smaller, you need more properties. So I'm expecting that eventually, perhaps in some of these companies, Noritake in particular is my favorite to win this competition, would say, oh wow, we have a market because we have a material in the drawer. So they just need to make it available in the blocks already commercially available, and use this splinter technique or double layer, which we investigated in 2004. And we are doing another study to make sure that the mechanical properties or bilayers are favorable. They may not.
Yeah.
Depends how you assemble it.
So for those that are sort of not familiar, this is the sort of strong zirconia bar structure with the hot bonded overlay.
For example.
Yes. Okay.
Yes.
So we're still in the early days, but I mean, those that sort of are producing it and using it are fairly confident in the material. What are people getting wrong with zirconia as a material, do you think?
There was a case 10 years ago. I was lecturing zirconia, and some colleagues decided to start doing full arches, because maybe it was more than 10 years ago. It was actually with Nobel Biocare. And after 1 year of studying all my lectures, they called me and said, well, we did the first case and he failed, and he fractured. So the technician did another one, build it up, and the second one fractured the day after we inserted. So I make the story short, I did a bit of investigation, and the person was doing that had a massive experience with full arches, mainly by converting an acrylic denture, by making holes, putting your temporary abutment, injecting acrylic done. But this is a different situation. So he took an impression, didn't verify the impression. The zirconia wasn't fitting because he admitted that all 6 screws actually put on the 5.
Yeah.
And then obviously you have a bending moment on the porcelain layer and you fracture. And that's the study we published in 2004 predicts that. And so the accuracy is crucial.
Yes.
Passive fitting is crucial. You know, it's not difficult at all. In particular now with photogrammetry and every all technique that you have digitally, but needs to be, you have a few steps that you have to be careful about in the design of a fitting surface. So let's say it's not as forgiving as an acrylic or like a PMMA, but it's very rewarding.
Yeah.
So you just need to be a little bit careful on some steps.
Yeah.
Not difficult.
In our own practice, obviously, I've done traditional all-on-4 for a long time, and acrylic, and worked really well for us. So we were reluctant to move away from it, but I think you find the more volume you do and the more complications you have with the acrylic and the maintenance, it becomes draining on your practice.
Absolutely. But that's exactly why, sorry for interrupting, it's early 2004 like this. You know, we had in Italy lots of experience with acrylic. and before gold alloy and porcelain. I can't use gold alloy porcelain anymore, obviously. There's no need to talk about that. But the acrylic to me was just not rewarding. You see the stain, you're chipping. And even if you tell the patient, by the way, you're going to have chipping, you're going to have fracture. It's a bit like when you buy a Fiat, let's talk, that you're going to have it fixed. But you're still pissed off, isn't it? And you say, why does it behave like a, I don't know, Mercedes?
No, it's exactly what we found. Those patients soon forget about those conversations. We've noticed with Zirconia, obviously, I don't have the same material science knowledge that you do, but things like the angulations of the abutments are more crucial, and so we can mill more accurately, and it has brought in a new sort of some complications in terms of the angulation has to be better, the space is critical. But do you think
if you see the all 2 days with Nobel Biocare, has really been about accuracy, isn't it? As a key word.
I don't think we would get
whatever material you put on top.
I don't think we would have got the same results without the photogrammetry coming in. And do you think there's much further we can develop this material?
Absolutely. I think you see the curve has been, we have this 3Y zirconia, which is a good compromise between mechanical properties and aesthetics. And then we want more aesthetics. So more translucent. And I found not smart in sticking to a material with very good mechanical properties and not giving away that material for something too translucent, because it would have been a disaster in some situations. And so we use a variety of materials in the laboratory that we own and share with some colleagues. And you can see when you push it too much, mechanical properties, and with this study as well, definitely drop so much that you see failures, you see problems. So now after this curve, with aesthetic, now we're going back to mechanical properties. How do we get the best of the two worlds? We working on this bilayer system. So you put the stronger mechanical properties, the kind of way you perhaps have some tensile stresses applying, and you put the aesthetics where you need, and you still keep this almost monolithic with very minimal layering if you really have to. So if you have a very aesthetic material on top, you can afford to stain. So that's why we're actually working a lot on staining technique as well.
So I think the future is promising for this material.
Yes. I wouldn't walk away from zirconia and embrace PMMA.
I think also maybe for the
or 3D printed. Temporary.
I think for the less experienced listeners, I think what they do need to understand is some patients, though, will still break everything you put in their mouths, potentially.
Someone will manage to do that. Yes.
Okay, moving on to the other topic that I really wanted to get your opinion on, what the impact of systemic health is, and in particular vitamin D, because I know you have some personal experience with vitamin D deficiency as well. So I found that conversation fascinating, and I would like to sort of delve into that a little bit. Talking about systemic health and things like that, maybe where do we start? Are you routinely now blood testing all patients? So can you tell me a little bit about your protocols?
Okay. Well, first of all, vitamin D has always been a topic. It's not something, oh, wow, vitamin D. I was a kid, and I remember my mom giving me smelly oil with vitamin D inside, and I was running away, didn't want to drink the oil. Because I know it's important for your bone formation, but I was, 3, 4, and so on. So it's not something, we just found out that vitamin D is important. It's always been vitamin D deficiency is a problem. I remember studying dentistry, and there was a big chapter of bone development, vitamin D deficiency. So it's in there. And it's sort of things that you don't maybe focus too much, because there are so many factors that are important in the success of dental implants. Okay, so vitamin D you don't consider. And then I'm doing my residency in prosthodontic, and I feel really tired and depressed. And we actually, when we starting the test, the course, we're doing this psychological assessment. We tried perform extremely well, but depression. And I was working too much. No sun exposure. I'm not a really depressed person, so I'm really quite okay. So I had the blood test. My vitamin D was 28, which is very deficient. Result of beautiful lifestyle. well, student and so. And I knew that I would pay the consequence of that. So, okay, top it up. It took 3 weeks to see a blue sky. And actually, that makes me wonder how many people are depressed and they take particular medications. In reality, you need some drops of vitamin D, but that's a different topic. So 3 weeks, you're just okay. So the knowledge remains in there. And then I bump into, you keep studying, you keep seeing. I saw a conference on PRF, and there was this anesthetist talking about PRF, and he mentioned vitamin D superficially. I was like, oh, we really need to look into that. And the first case was maybe 10 years ago of this lady, 28-year-old. She comes to the surgery with this type of posture, and she's a real estate agent. She's gorgeous, lost a central incisor, and she has been trying to fall pregnant. And we place this very easy central incisor, and we graft her, and everything is healing, but slowly, very slowly. You see the soft tissue reacting. You do lots of things like that. You can see,
It's not healing well.
Healing, just getting there will be okay. So I'll wait a little bit longer. And she's young, she's healthy. Put a provisional on. I'm talking about months after. Put a provisional on, and finally a torque. And the very last millimeter, the sedge rota is about millimeter. So it was just, I said, wow, this is so weird. And I decided to have a blood test. What's your vitamin D? It was 20.
Okay.
So very low. My 28 was miserable, also almost inexistent. So 20. So okay, we have to top it up, and left the provisional in there. She comes back after 3 months, and she's got different posture, and she's happy. She's pregnant.
Wow.
So I don't know, but if you study exactly what vitamin D does, and how affect the immune system, depression has a big component. Vitamin D is not a vitamin; it's an hormone and regulates so many things. And obviously, I remove a provision, take impression, the soft tissue is growing, papillas have developed as they're supposed to be, and so on. So I say, well, okay, that had really an impact on this person. One case doesn't do a study. So we started being, would you mind to give me your last blood test with a vitamin D? Because it's quite regularly asked by GP, And interesting that unfortunately the University of Sydney had a sort of a campaign through one of the schools. They did a study showing the abuse of blood tests requests of vitamin D, and show the impact from a financial perspective. And so the paper was very disappointing for me, although it was highly celebrated in the website. Look how good we are in, selling money to the government. But in reality, they really missed the point. For example, there was a study on dermatologists, and 85% of dermatologists turn out to be deficient in vitamin D, which is a massive problem. So, okay, you don't get melanoma.
It's in the damage of the sun.
Yeah, exactly. So from that point on, we started being very strict on vitamin D, and you develop that clinical sensitivity. You see a person deficient. I can tell.
You see it.
Just look at the face, deficient. You have a blood test, and then you investigate. We don't necessarily send a patient to us, just show me an old one. And typically when people go to the same laboratory, they come back and you will see the history. Because the problem comes with the fact that as soon as the range is of normal is 50 to 150 nanomoles per liter. So if as soon as you touch 50, that's okay. I really want my patients on 100. And there are studies showing if it's too high, apparently that's not good for the bone either. If it's too low, that's not. So 100 it's a good range. Controversial, there are not many studies. Some people say, no, you should be much higher. But I don't feel like recommending that, because we don't have the evidence that high vitamin D is actually positive. We do evidence that is not positive. So it's a range.
What about the patients who say, I've never had a blood test, or I haven't had a blood test for 2 or 3 years? Are you going, right, go get one?
Yes.
I mean, that's probably a good thing. And, it's amazing how sometimes what we tell them can help with their health as well.
We found very interesting things.
Yeah. Yeah, we did the same. Like we were blood testing more patients, especially the all-on-4 patients, big surgery.
Yeah.
And diagnosing diabetes and things like that, and getting patients on a bit of a...
I have to say, response of surgical patients, and 90% of patients had a very positive response to my request.
Yeah.
I have the same protocol for TMD patients.
Okay.
When they come, they want to have a solution now. And I really found difficult to do a clinical examination only and give an answer. And we found imaging very, very, very useful.
Okay.
So we send patients for MRI. And if we don't do in the surgery, cone beam CT scan of the joints, actually, we do have a cone beam CT scan machine, but we don't do it. We send it out intentionally.
Okay.
There's a reason for. It's interesting that patients for surgery respond very well to the request of blood tests. In TMD patient, 70%, if you ask imaging, would disappear. That's all. Symptomatic in a way. But when they come back, if they come back with the imaging, we always learn so much that can actually allows us to tune the treatment in a very different manner. Okay. So yes, we ask for a blood test. We want to have a number. We want to know.
Yeah. And so what are the other key markers maybe you're looking for in the blood test?
Okay, I think an important thing K is very interesting.
Yeah.
So vitamin D should be with K.
Yeah.
K is the one that gives direction. So if you don't have K, the calcium may actually be deposited into your arteries.
Yes.
Whereas if you have the K, direction changes, and the vitamin D would deposit calcium into bones in particular. So that's why when you have supplements of D and calcium, to me, it's wrong.
Yeah.
So you have D and K. Personally, I use a supplement which is sublingual.
Yes.
A spray. I don't like tablets very much. You can have tablets. There's no difference.
I bought the spray after talking
to you
at the last conference.
Yeah, we are. So I find it very easy.
Yeah.
It's oily, absorbs through the tongue. And our protocol is patients are deficient. We put it on from a minimum of 2,000 to 5,000 units for 1 month.
Yeah.
So we delay the surgery a little bit. Actually, 1 month is very difficult, but we do surgery the day after. So normally with the appointments, 3 weeks is pretty normal, 1 month. So that gives them time to build up the vitamin D. After that, we go down a bit. I think 5,000 units will be very high.
Yeah.
For 1 month is okay. And then you can easily drop to 2,000 units.
Okay.
GP typically recommend 1,000 units.
Okay.
So don't be surprised if you get a letter from another specialist telling you that you should leave this type of topic to the GP or another specialist. A dentist should not look into that. I disagree.
Yeah. So
but we go letters like
you're retesting?
I invite the patient when you have the blood test, make sure there's vitamin D in there.
Yeah.
I don't send it. We know from experience, we've done so many situations like this, you pump it up to even 5,000 1 month, it's not going to be toxic.
Yeah.
And then go down to 1,000, 2,000 units. The best that you can get, obviously depends how big the deficiency is.
Yeah.
If a patient is around 70, just give 2,000 units.
Okay.
And do you have 70 is not.
Do you have any particular brand or a thing you?
Okay, I use Biocutical.
Yeah.
Which is, I told you, spray, sublingual, it's DMK. It's a little bit more expensive what you find, but you don't need that much. So it's reasonable as overall price. But you can buy Metagenics is a very, supplements are not regulated, so it's dangerous.
Yeah.
So maybe I should recommend to change brands, because so you don't stick to one, and maybe it's the bad one. Who knows? Okay. But Metagenics, Biocutical, serious brands have a reputation, so I hope it's okay.
Fascinating. So
that's a problem.
I think we spoke about it before, but you kind of said, we're not testing this though, because we wouldn't have a group of patients and say, hey, we're not going to give you vitamin D if you're deficient.
Actually, there are tests.
That's
meta-analysis.
Okay.
Controversial. There's a study on sinus lift, and they actually compare patients with different supplement without supplement. But then again, the group that didn't have supplement had a very normal vitamin D levels. So obviously the supplement is interesting only if you're deficient.
Yeah.
And for us, deficient is not less than 50. For me, deficient is less than 80, 90. Yeah, I want to be between 80, 100, 110. So that's ideal.
Yeah.
So it's an interpretation of the numbers, which is important.
And what about post-operatively with these patients? Or what are you doing anything different with these patients? I presume just continuing the vitamin D.
Try to keep the vitamin D level. And I have to tell you, I don't know if it's psychosomatic, but the last 2 years, my family had a few problems with the house. We move a lot because the house is under renovation. And so, you move, you change your routine. I actually stopped using vitamin D for a few months simply because I forgot. Okay, I forgot. And at some stages of it, oh my God, I'm so tired this morning. We have long hours. I deserve to be tired. There's no doubt about that. And then I said, oh, when did I take a vitamin D last time? I don't even remember. So, okay, go back in. And after 2 weeks, that's gone, that sense of fatigue, which is a typical symptom of deficiency. And if I don't take it, I will be deficient for sure. Because my diet also is not ideal for vitamin D intake. I have no exposure to the sun. I can really, if I go under the sun, I burn in 2 seconds. So I really have to, So I have no alternatives. I have to take a supplement, and if I don't, I feel it.
Yeah, I mean, it seems to be a growing issue in Australia because of that fact.
Yes.
Because we've got the risk of skin cancer here. Was there anything else you wanted to discuss around that topic in terms of?
Maybe, just to say that there are plenty of studies in dentistry now. There was a meta-analysis from the editor of the Journal of Dentistry showing that patients with vitamin D deficient have a 300% probability of failures or let's say survival rather than success in dental implants. So there was a clear link between dental implants, failures, complications, surgical obviously, and vitamin D deficiency. So it's not a new topic. There's also lots of study in perio. So with vitamin D deficiency, periodontitis, and so on. So it's nothing new. There's nothing new. It's not. I'm not here to say, oh wow, look at this, is a new study.
I think I personally think it's something that's just not looked at enough, though. I think, especially with the amount of general dentists doing implants. I think what I always say to general dentists when we're lecturing and stuff is, the difference is specialists and surgeons, they're very used to doing extremely detailed medical assessments. They often have more medical knowledge because of their university background. And I think the general dentists tend to skim over it. They give them a sheet. Oh, everything looks okay. They don't delve too deeply. Hence, why we've had some, I wouldn't say scares, but we've definitely seen some correlation between systemic health and poor healing. So we are blood testing a lot more patients, especially if we're doing complex surgery. And the other key thing I think you spoke about was the timing then to surgery. Like, there's this eagerness sometimes to treat the patient, right? Now, holding back and saying, get your health in order. So, I think we shouldn't be treating these patients too quickly. If we're going to put them through surgery, we need to give them time to sort themselves out.
But you're so right. We really need to resist to that. And each time I do it, I'm saying, oh, thank God. I have situations really. It's now routine for us to contact the GP and ask an update, medical history, list of medications. There's always something missing from what the patient told us. In one case, there were 28 pages missing. And so that was quite dramatic. But beside that case, this is our routine. My receptionist doesn't even ask me. Plus, GP find it very easy. It's just email it. And if there is no information, and then we ask the minimal. Sometimes I have to say we perhaps don't have enough knowledge to understand everything. For example, we had a case of a nutritionist with, this is a bit complicated, but she had a normal level of vitamin D, but symptoms of vitamin D deficiency. And turned out that she had the deficiency of K. And that's why the two things go together. And the blood test for K is a bit more complicated. It's a bit more expensive, and the patient needs to fast. So I ask only seldom in some specific cases. So again, to have the knowledge to understand these cases is we don't have it. You need to study on that. My wife is amazing from that perspective. So she is really leading
Yeah.
from rather than me. I have to be honest. So she's more into that.
Yeah.
She's into nutrition, health. So we obviously discuss because I'm doing the surgical side.
Yes.
And it's nice to, again, team approach. You can't do everything by yourself.
No.
It's so good to work with people and like what we do now.
Yes. Yeah.
And exchange. Yes.
That's fascinating. And we'll wrap it up soon because we've both got other things.
Commitments.
I'm lecturing this
Yes.
afternoon. I think you were on stage yesterday.
I was yesterday. Yeah.
How are you finding the conference so far? The Nobel conference?
Conferences for me are always, each time I leave, I go back home, I want to do more.
Yes.
Just you feel like that. And I think that's the best feedback that I can give, is just really and meeting all these people.
Yeah.
And see what they do to themselves. Look at what Alessandro did yesterday at 11 p.m. was still in there working. At 6 a.m. went to the hospital and he said, oh wow, I'm not the only crazy one. And we know that this is not healthy for us. We just can't help. We just really
Can't help ourselves.
You need to be part of this. It's too exciting to grow. And the company itself, think about the number of products they develop, they put on the market. It's hard work behind that. And they take bit risky each time they came out with something that can be accepted or not in this very competitive environment. Yeah, I've been with Nobel Biocare since '92, and it's a great company. And this is where I'm gonna die.
Yes, it's good to have these conferences back. I've been involved with Nobel Biocare, for much less time than you, but it's sort of these conferences. There's only so much you can learn in a short space of time. But like you say, it's that motivation factor. It's okay. This is what's achievable, and what can we take back. So I always go back. More knowledge, better motivation, and normally some new friends that I've met along the way.
And even if you can't achieve, for example, I'm not interested in zygomatic. My background is oral surgery, and I know that to develop those skills, you need 30 cases, development phase, which were 30 cases where you say, oh shit. And do I have all of these cases? No, I think I'll refer to someone can build up to the 200 cases per year. Lydia Lim, in Sydney, I'll send it to her so she can develop that many skills. But I like understanding the potential, so that we can understand. So you don't need to take whatever it's here and use it. It's nice to know, and then focus on what you think is appropriate for your setup and what you want to do.
Yeah, and any educational stuff you're working on yourself?
Oh, thanks for asking. A lot. We have a course called Master Prep, which is on in November, and is dedicated to people that want to do fixed prosthodontics on teeth. Started as a bet with the ADA. Years ago, they said we need a basic course. It became more and more sophisticated. We have our center in Barrow, just outside Sydney, which is beautiful setup because there's nice accommodation, restaurants. We spent 3 days together with very nice people, and is focusing on preparation, but treatment planning also for fixed prosthodontics. So we range from posterior dentition, inlays, onlays, veneers, anterior, in 3 days. So the focus is, the keyword is preparation, but in reality there's lots of how do you get there, treatment plan and so on. There's a bone grafting course coming next year. We organize also digital with SAMDs. So I only do very little in that course. It's mainly Sam. You know SAMDs?
Yep.
Yeah, so it's the genius of of digital. It works with us, and it's amazing. We developed so much with him. In particular, a new concept on occlusal splint related to the anatomy of a fossa. Very, very, very interesting. Maybe the topic of another podcast.
That's great, because the market is just swamped with implant education at the moment, and my background as a general dentist was that I did prosthodontic residency, mini residencies, because when I came out of dental school, I realized I actually didn't know how to prep teeth properly or plan, and I think fixed pros is not a forgotten art, but it's dwindled a little bit. Everyone's steering towards implants, but we as an implant practice, a lot of patients are still recommended a fixed bridge
Yeah.
instead as a better
Yes.
option. Yeah.
Yeah. We do all on fours, we do full arches, but we still safety. It's really, it's a big component of the practice. And I don't do only all on fours, just really, thank God. So I know some people love doing that, but I think I like looking after the patient, and it's not necessarily like that.
And where would people find out about these courses? Do you have a particular website?
Yes, we have a website called Highlands Professional Development, which is highlandspd.com.au.
Yeah.
Another course that we do, super interesting, is every January we run a seminar in the Dolomites.
Okay, so this, I saw the pictures of this. It's like a phenomenal. I'm a big skier myself.
Oh my God, you have to come. You really have to come.
Yeah, I'm in Japan this January, but I'm hoping maybe the year after I'll come.
It started again, like, this is where my family is from. That's my area, so I was going back and visit my family, spend 1 week in the Dolomites, very close to where the Olympic Games were.
Which resort?
So it's the village is called San Cassiano. Cortina d'Ampezzo, the Olympic Games were, one of the, is actually half an hour away.
Okay.
The way we are is heaps better for skiing. It's much less expensive, but it's so much nicer. Obviously, when a place becomes popular, famous,
it's busy.
Yeah, and from a skiing perspective, Cortina is not as beautiful. They still connected, so you have 760 kilometers of slopes.
Wow.
Connected without taking your skis off. And where we are, you can reach all the borders of this universe of skiing. So whereas Cortina is really in a corner, so you miss the rest. And we've been doing this maybe for 10 years. And we started because they said, oh, it would be so awesome to bring some Australian friends and show where I'm from. And Linda, my wife, said, let's organize a course. And the course is really to stay together.
Yeah.
And we had Glenn Lillo, Graham Carmichael coming multiple years, Terry Walton, Danielle Layton, Robert Phil, and they presenting as well. So maybe in different time, So the level was very high. And we present from 5 to 7, sometimes 8 with stretcher. And I see how professional these people are. Some of them, are you skiing today? No, I'm presenting. So what do you mean? No, I'm not going skiing. I'm staying here because I have to fix a presentation. So it's amazing. That's very amazing. Just give a presentation. Gave last year. No. There's some update or something.
Yeah, and I know that's
exactly unbelievable.
Are they as competitive with their skiing as they are their lecture slides?
Of course, in a good way, I have to say. But I can give you an example where there's a little shop where you can rent your skis. There's some amazing with the last equipment to prepare everything. But I go to this guy and not very fancy, but the skis are amazing. When I say amazing, I'm renting, for example, Volant, handmade in Austria and difficult to buy because there are only a few shops. Now it's owned by Atomic, but it's a niche product. So they behave like a racer ski, but they're much easier. You go 100 km per hour, vibration is minimal. How do I know there's an application of a telephone? Because we're mad.
Carver, is it the Carver app you have, or no?
It's all carving, obviously, yes. And when I go there rent it, they brand new. They're just perfect. And I use it 4 days. I go back, redo the edges. So it's just very unique and inexpensive compared to United States, other places. So compared to Italy, it's not cheap, but it's a fantastic service. If it's a good season, snow like Olympic Games, so snow everywhere. If it's the best season, which happened once in 10 years, no snow. These people are so professional in this region. They have this reservoirs of water, and you can see these tanks of snow, basically. And you can ski beautifully without a stone or anything outside. And it's brown on the side. Sad, but if you have the best season, you still guarantee that you will ski, which is amazing.
I've skied a couple of times in Italy, in the Tuile and Sazadu. So
spent lots of time. I used to have an apartment in La Tuile. It's
fantastic skiing there.
Yeah,
fantastic. It was very quiet when we went. but that's also good because you're less tempted to go and drink in the bar and more tempted to enjoy the skill.
It's quiet because all around you have major resorts like Cervinia, Courmayeur. If for some reason people don't like La Tuile very much, it's windy as well, cold compared to the others. But I used to have an apartment in there and I really loved it.
Yeah, it's a great
Really
resort.
loved
Great
it, yes.
resort.
And do lots of ski touring as well.
Well, I hope you can add me to the list
hope so.
1 year. So I'd love to come and join you. So, okay.
Increases your vitamin D level.
Of course. Of course. Right, well, I think we'll wrap it up there, Max. I need to go and actually go through my lectures again. Appreciate your time.
Good luck with it.
Always fascinating speaking to you.
Right.
Our listeners, I'll share the link to your website on the podcast. And
Fantastic.
yeah, I encourage them to go and listen to you because not only are you full of wonderful knowledge, but you're also a very, very entertaining speaker. I've heard you speak a few times, and you always make everyone laugh as well. So encourage people to go listen. Thanks for joining us.
Thank you very much.